This podcast contains our own personal views not associated with any organisation. Coronial contains descriptions of death inquests that may be graphic and disturbing to some listeners. Discretion is advised. Welcome back, everyone, to Coronial. I'm Georgie.
I'm Emma.
And I'm Alice.
So this week I'm going to tell you guys a story that you both heard already. And I feel like for me it's actually kind of the origin story of how this podcast started, because this is that one that I talked to a lot of people about that then kind of got us interested in talking about inquests. And I feel like it was the story that I told you, Alice, that you actually got interested in them, versus I know, Emma, that you and I have read inquests for years. And so I was like, you know what, I'm going to go back and look at that one. And actually looking at in a fresh light for this was really interesting, because I remember how much judgment I had at the time and how did that even happen? And reading it back, I'm like, okay, a person made a mistake. Things were not dealt with as ideally as they wanted in a medical situation, but that the person involved had in fact made lots of changes in the time that it had happened to the time of the inquest. And yeah, I like the way that this podcast has reframed the way I think about inquests, or the way I consume them now as well, in terms of... So this is why we're listening to this one, and apologies that you therefore have heard me tell you this story before.
Look, at the moment I'm having trouble remembering it because my memory is really bad. So
I haven't got into the details so far yet, but I think once I start, you'll be like, oh yeah, I remember you talking about this. A lot. Anyway, we're going to talk about the death of Mrs. Willersdorf, who died on the 19th of April 2015 following a radiologic procedure 5 days prior to her death. But primarily it's the radiologic procedure that was reviewed in this case. So Mrs. Willersdorf was 87 at the time of her death. And so just a bit of background about her. She was born in Innisvale and grew up on her parents' sugarcane farm before moving with her husband to Brisbane in the 1950s. She was the mother of 4, grandmother to 13, and great-grandmother to 15 children.
Wow.
Yeah, I know, right? I'm
That's
impressed.
a big family gathering right there.
Yeah. So Mrs. Willersdorf was known to have chronic back pain, secondary to the arduous responsibilities that she'd had on her family farm growing up. And then also as the result of rheumatoid and osteoarthritis, as well as osteoporosis being the brittling of bones that had all led to this pain. She was known to have multiple fractures of her vertebrae, so the spine, and ultimately in her life she'd had a fixation of her lower spine due to the arthritis. So the lower segment of her back had all had some metal wear put in to hold it in place to reduce the amount of pain that she was in. Just additionally, in terms of her health, she also suffered from abnormal cholesterol levels, borderline diabetes, and shortness of breath when exerting herself. But she was 87, so none of that particularly surprises me. It was due to her escalating back pain that she presented to her GP on a couple of occasions, which then prompted a referral from her GP for steroid injections of the offending joints of her lower back. And actually, realistically, it's kind of more the midsection of her back, sort of where the ribs end, that was giving her trouble. Yeah. The procedure that is done is guided by imaging so that you can get the needle in the right place. So it's often completed by a specialist doctor known as an interventional radiologist. During the inquest, the GP further clarified that at times Mrs. Willersdorf had been reliant on significant amounts of pain relief to control her back pain, had mobility restrictions as a result, and had previously, as I mentioned, needed surgery for it. So it was in consultation with her that they were investigating the possibilities of alternate management options, such as this referral for injections, with the plan being that if the injections reduced her pain, that they could therefore determine that the pain was coming from that area of her spine, versus it being an alternate origin of her pain that would need different management. So she attended the radiology clinic on the 14th of April 2015 for the injection. So she initially underwent a CT scan of her spine at 11:30 in the morning. These images were reviewed by the radiologist, who then completed the procedure between 12:48 and 1:05. And in the report that he provided back to her GP following the procedure, it was described as unremarkable and without complication. Following the procedure, Mrs. Willersdorf was able to mobilise to the bathroom, but shortly after this, her health deteriorated. She became unsteady on her feet and needed assistance from the radiographer, so the staff who assisted with taking the images, not the one who was doing the procedure. And then because of this, she was taken into another room to rest due to her symptoms. It was at this point that she fainted, but quickly recovered. Mm-hmm. However, care was taken over by the practice manager in terms of supporting her, so just another staff member in the radiology practice.
And was her CT with contrast?
Yes, I believe so. Mm-hmm. Additionally, at this point, she was also reviewed by the radiologist, the person who'd done the procedure, and then subsequently fainted again, leading to the radiologist checking her blood pressure and her pulse. And at this point, her blood pressure was found to be 60/40,
Ooh.
The normal being 120/80. Hence, the radiologist inserted a venous cannula. So presumably, if she'd needed contrast, they'd already taken a cannula out, and provided 50 mils of fluid. And just for clarification, 50 mils is less than a quarter of a cup of a standard measurement, just so everyone's aware.
So it's probably not going to do much for her blood pressure.
No. So given she was unwell at this point, the Queensland Ambulance Service was called at 1:37. But at this point, the radiologist left Mrs. Willisdorf in the care of the practice manager while he attended to other matters. The radiologist stated during the inquest that these matters included making clinical decisions to move patients, waiting for imaging rooms, and to clear the room for emergency services personnel. Which I wrote a note, gave me vibes from, do you remember the aged care case with, I think it was Fred who fell into the drawers and they left like the personal assistant type person while the nurse went to go get the ambulance?
Yep.
Very much those vibes have left the non-medical personnel to care for the person who was having a medical emergency while the medical person went to go
clear the room and stuff.
Yeah. It only took the ambulance 8 minutes to arrive after the commencement of the initial emergency services call. On their arrival, the advanced care paramedics that arrived reported finding Mrs. Willisdorf lying on her side on a procedure bed. She was unresponsive and not breathing.
Oh.
And no life-saving measures were being performed.
What? Oh, no.
The paramedics were also unable to find a pulse.
Oh, my God.
And one of the paramedics reported during the inquest that the practice manager was positioned by Mrs. Willisdorf's shoulders at the head of the bed and appeared to be consoling her.
She doesn't need consoling. She needs CPR.
Ideally, yes.
She's not upset. She's dead.
She's dead.
On questioning by the paramedics, the staff reported that Mrs. Willisdorf had been gasping for breath up until about 5 minutes prior to their arrival.
Oh, my gosh.
And then when asked if anyone in the practice knew CPR, no one responded.
Excuse me, what? It's a medical practice.
The paramedic also described being unaware of the whereabouts of any medical personnel in the practice at this point.
So the radiologist is just nowhere to be found?
Yeah, the paramedics essentially reported that they didn't really meet the radiologist
The person who is essentially responsible for her care.
Yes.
And who should know CPR.
Yes.
Because they are a doctor.
Yes. He did know CPR. Just to clarify.
Wasn't there.
Yeah.
Just wasn't around. Cool.
Yeah. During the inquest, the radiologist contested the paramedic's assertion by stating at the time of their arrival, Mrs. Willisdorf was not cool in temperature, had shallow breathing, and had a pulse. But as I described, he wasn't present in the room.
So how
at
does
the
he
time
know
they
that?
arrived. Yeah, his assertion is difficult. So the paramedics commenced further assessment of Mrs. Willisdorf and reported that she had her eyes open with fixed and dilated pupils.
Oh, no.
CPR was then commenced.
Doesn't that mean there's like no brain activity?
Yeah, look, if someone's got fixed and dilated pupils, I wonder about how successful CPR is going to be.
Okay.
CPR was commenced, but they had to move her off the bed that she was on to find a more suitable surface for them to perform chest compressions. And remember that at this point, she was lying on her side. So they hadn't even put her flat on her back to like even consider commencing CPR by this point. So they started chest compressions. But because they had come in thinking that they were coming to someone who was unresponsive or had a faint following a procedure, they hadn't brought any equipment with them that they would require. So one paramedic was required to start and continue CPR, whilst the other returned to the ambulance. They advised QAS of the situation and requested further assistance, and then also grabbed further equipment to continue with the resuscitation efforts. Another paramedic then attended and also assisted, and it took them 20 minutes before spontaneous circulation was in fact restored.
Wow, okay.
Wow.
Yeah, which I think is also impressive though.
that they managed to get that. But also that's a long time with no oxygen to your brain.
Well, no, in the 20 minutes they're providing CPR. She may be getting oxygenation. And then she was transferred to the Gold Coast University Hospital, but unfortunately did not recover from this event and died 5 days later.
That's
5 days?
Yeah, that's a long time, but I'm guessing they had her on life support.
She obviously had return of spontaneous circulation, but I presume she was intubated and not awake.
Yeah.
And so it didn't really go into what happened in those 5 days. The cause of death at autopsy was determined to be a hypoxic ischemic encephalopathy, which is an irreversible brain injury, following a cardiac arrest, which was also complicated by valvular heart disease. And this was only identified on autopsy, so it wasn't known that she had valvular heart disease prior, but also not unexpected in a person of her age.
Yep.
Her treated spinal osteoarthritis was determined to be a significant condition as contributing to death, but the person performing the autopsy said it was not officially related. However, the coroner, in their findings, did think that it was contributory to her death. Ultimately, at the end of all of this, the coroner went, yeah, you've said it's not contributory, but I think it is.
Yep.
And so I just found that really interesting that the pathologist doing the autopsy didn't consider it to be contributory, but I'm like, but if she'd not had that procedure, she probably wouldn't have had that arrest, and so she probably wouldn't have needed this autopsy.
But I guess trying to find the proof of that in an autopsy is...
It's not that you need to find a proof. I think it needs to be considered as a relevant event to how she had a cardiac arrest in the first place.
Yeah.
But yeah. So the main issues that were investigated at the inquest included reviewing the procedure that was performed, whether the radiological practice responded appropriately to the medical emergency, including the personnel's response as well as the equipment available to them at the time, and then the emergency services response as well. So just a little bit of background to the radiology practice. It was a standalone radiology practice in Queensland, and that radiologist who was there performing the procedure that day happened to be the owner of the practice as well.
Yep.
And the practice manager happened to share the same surname as the radiologist. I'm making some assumptions that therefore it's a wife or a daughter that is the practice manager.
Would make sense.
And I think that just like for me clouded that reliability of the two of them when they provided their understanding of events.
Their account of it,
that they may have been trying to protect each other in their accounts.
Even if not deliberately, but maybe subconsciously they were.
And then of note, the radiologist is the only person that was there and available during that day with any kind of medical training. The rest of the personnel were not medically trained. So the radiographer just takes the images and doesn't have any requirement to be medically trained, and the practice manager had no medical training or clinical skills. And there were no other like nursing staff or other people there.
No one else who had done a first aid course even to know CPR.
We'll come to that.
Okay.
So the procedure that was performed, as I mentioned, the GP had requested a injection of the facet joints, so the joints that connect the spine together at the back. And then the radiologist sent a report back to the GP following the procedure, as I said, saying that it was uncomplicated and that a mixed steroid and local anesthetic injection was provided into the L23 epidural space, which is not what the GP requested, because the GP requested a facet joint injection and the report came back saying an epidural injection. So just to give you some detail, an expert witness described that an epidural nerve block is a pain relief procedure that involves the injection of local anesthetic and or corticosteroid into the epidural space. This space is located between the bone of the spine and the membrane lining of the spinal cord. And most people are going to know this procedure in terms of pregnancy and that women get epidurals when they're in labour.
Yep.
And that people who have an epidural essentially end up numb from the waist down if it's local anesthetic. If it's a steroid, that wouldn't cause that reaction. The most common side effect of an epidural anesthesia, though, is known to be hypotension or low blood pressure, and can be profound, especially in those without significant reserves to manage the blood pressure, such as elderly people. And so this expert witness stated appropriate monitoring of vital signs, blood pressure, heart rate, oxygenation, is imperative during such a procedure and following it. And I guess I didn't specifically mention, but there was no monitoring. She was get up off the bed, walk out to the waiting room, happy for you to go home now.
Yeah, and they did check her blood pressure, but only after she had fainted.
Yes.
So there was no monitoring before that point.
No, they were just like, you can put your clothes on and leave now after the procedure.
Do we know about how she got there? Was she drive herself there, planning to drive herself home? Or?
It didn't talk about how she got there or what her plans for leaving was, but it does come into some of the recommendations around if you're doing this procedure, it should be one that involves a secondary person to be discharged into the care of. So I presume that she didn't, whilst it didn't specifically mention, I presume she didn't have anyone else with her at the time.
Yep.
So the radiologist who performed the procedure also then went on to provide 2 further conflicting reports during the inquest about the procedure that he performed. So, as I said, his initial report stated that he did an epidural at the L2-3, which, again, it's just one of the sections of the lower back.
Mm-hmm.
He then said that he performed it at L3-4, so just the next level down. He then also stated that he actually did a facet joint injection, the ones that the GP had requested, at L2-3.
But, I mean, you've got to assume that the report they did immediately after doing the procedure is the correct one.
You would think that.
Because you've literally just done it. Your memory is fresh.
The radiologist attributed his initial error to dictation, saying that, I just reported it, someone typed it, they typed it wrong, and then when I got it back to read and sign, I didn't take due care in reading and signing what was written. But I then can't understand how the subsequent 2 statements came to be then, because even if that was the case, like, you can't go from an epidural to a facet joint injection.
Yeah.
That's not...
Getting the number of the L's, yes, I can see how you get that wrong, but epidural and facet sound nothing alike.
And are not at all the same procedure.
Right.
He further went on to discuss in the inquest why he performed an epidural instead of a facet joint injection. It was said that when he viewed the initial CT that was taken, he determined that there'd be too many joints to inject, that they were all very arthritic, and so the better plan was to just do the one epidural that would like essentially cover pain relief for all.
Does he really have the authority to be making that decision, though? Because surely it's the GP's decision as to what the treatment is. You're just providing the treatment as prescribed.
So they said essentially there were 2 ways of going about that, and there was a long discussion in the case that I didn't necessarily go into a lot, but you're right. Like, if he is performing a procedure just as the function because the GP can't do it themselves, then yes, he probably should have performed what the GP had requested. And especially in this case where the GP was like, but I detailed this plan with her in terms of we should do this to determine if that's where your pain is coming from. And so therefore, like, doing an epidural to cover all of them wasn't along the lines of that plan. But the other part was, then they sort of went on, well, if he had made that call to change that plan, then he should have called the GP.
Yeah, had the
It was not an emergency procedure, so he could have delayed it in terms of doing another time if he couldn't have got onto the GP or wasn't happy with that plan. Or if he had therefore assumed the medical care of her to change that plan, because again, he's got medical training, he can do that, then he needed to have done that properly in terms of a medical history, talking to her.
Informed consent,
assessing what how the comorbidities were and all that kind of stuff, which there is no documentation or evidence to say he did do it.
Yeah.
Additionally, at the time of when this event occurred, he stated that it was actually the radiographer's responsibility in the practice for obtaining consent to the procedure, not himself. But then he went on to state that he did in fact meet with Mrs. Willersdorf to discuss the procedure and its possible complications, but stated he didn't recall if he discussed the risk of low blood pressure, but that it was not his normal practice to discuss this when he was discussing complications.
Okay.
But from all of that, I'm like, there's no documentation to say you saw her. It wasn't your usual practice to necessarily see them because you'd let the radiographer do the consent, which is also not what you're meant to do. Just to clarify, it should be the personnel who has the medical expertise to provide informed information around any questions you might have.
Yeah.
And the radiographer shouldn't be responsible for that.
Because, like, surely the radiographer can do the consent for a standard x-ray.
Yeah, simple stuff that they know and can
where
consent
they're going
for,
to be actually
but not the
doing
interventional
the
stuff.
Yeah.
And then he's then said he went and spoke to her, and I'm like, there's no detailed evidence to say that you did, and you're saying that it wasn't your standard practice to do that, so therefore I assume you probably didn't, but you have stated that you have, so I have to trust the evidence you provided.
Yep.
And then the other issue is that he said that if he had consented her, that he probably wouldn't have discussed blood pressure as a problem anyway.
Yeah.
And that was essentially the whole major thing, is like the drop in blood pressure was really what caused all of her events.
Yeah.
ultimately, when an expert witness then reviewed the images, because images were taken as he was doing the procedure, because he was using the images to guide.
Yeah, it makes sense.
The expert witness found that he, in fact, did an epidural injection at the site of T12, not L23, like he said in his report anyway.
And, like, that's close, but it's
different. It goes T12, L12, 23, 34.
But yeah, that's close in proximity, but it's not what you said you did in any of the 3 different accounts of what you did.
Yeah. So it's also just like, you've either been unaware or not kept good clinical records of what you've actually performed.
I'm not sure which is worse.
And then someone's come along and been like, but I can see on these images that that's not what you did.
Yeah. At that point, you're just like, whoops, I guess I did it in the wrong spot, or whoops, I accidentally wrote down the wrong thing. Yeah. Or I thought I did it there, but turns out you did it somewhere else.
Yeah. Yeah. So, yeah, it was really hard to reconcile, like, did he think he'd done something differently, or was he just not willing to admit where he'd actually gone? Or was he just so stressed and overwhelmed by the whole situation? But it doesn't seem like he conceded that because, again, in the 2 subsequent reports that he provided, he's like, no, I did it here, or I did what the GP requested. It's like, but there's imaging to say that you didn't. And yeah, he did this despite the request being for something entirely different. So, and then just to clarify, the expert witness did detail multiple reasons why he came to the conclusion of where it was in terms of looking at other surrounding anatomy. So it's not like the expert witness could just be like, well, I think it's this spot and therefore I am correct. He concluded that this was a significant departure from normal practice to do an epidural injection at that point because of various other anatomical reasons as to why it's worse to do it higher than lower that I don't need to go into, just if you want to read it, but just trust me on that in this one because it gets long and detailed. He concluded that at best, if Mrs. Willisdorf had therefore identified her pain that much higher up, then the facet joint injections, the simpler, smaller injections would have been better. But alternatively, it was more likely that her pain was actually coming from just above where the previous surgical fixation had occurred. And so then if it had been that was where it was going, then potentially you could have done an epidural at that lower spot. But that would have been more technically difficult because of the surgical interventions that were there.
Yeah, right.
Either way, expert witnesses were all in consensus that what he actually did was outside of normal practice and he probably should have just done the facet joints, or that he should have contacted the GP about, I think we should do a different plan. And yeah, there was no evidence to suggest the GP was ever contacted either.
Yeah, right.
So the coroner ultimately agreed with the majority of the expert witnesses. The coroner agreed that it was inappropriate for the consenting process to have been performed by the radiographer and that the radiographer shouldn't have been expected to have the expertise to provide answers to any questions that may have arisen from Mrs. Willisdorf. And additionally, the coroner criticised they were using a generic consent form that therefore didn't adequately identify risks and stuff as well on the form that she signed. And so the coroner concluded that Mrs. Willisdorf was unlikely to have been fully informed of the risks of the procedure that she underwent as well. So how much understanding she had of what was actually, what risks she had to herself undergoing this procedure. And so there was concerns about the validity of the consent in the first place.
Yeah.
So from that, the coroner made the following recommendations: that the radiology practice should amend their policy to allow patients to provide their consent directly to the radiologist, or if there's another radiologist employed at the practice in the future, that radiologist.
Yep.
Amend their practice to ensure the treating practitioner provides the patient with the full details about the intended procedure and the known associated risks so that the patient can discuss and ask questions from that person to be able to get a fully informed consent, and that they have the right to withdraw consent if they're not happy with the risks. That the consent form should be specific to the intervention that's being provided rather than generic to all interventional radiology. That they should amend their policies to require patients to provide their written consent unless in the event of emergency. So again, there's no obvious documentation about her consenting. So they're like, there should be.
Yes.
They should amend policies that require patients to be released into the supervision or care of an adult following certain procedures, as we kind of discussed before about that. That they should document what they do for their patients.
Accurately.
Yeah.
Amend practice to require recording and compiling of full patient medical history records and to record the details of each patient attendance, and that they should implement monitoring following certain interventional procedures for at least 30 minutes, including but not limited to a post-procedure recovery space, a nurse supervising, and then conducting regular physiological monitoring of the patient's vital signs, which they did not do. Which, again, is hard because it appears he thought he was doing a different procedure.
Yep.
It appears he was unaware of the exact risks of said procedure, or therefore the need for all of this follow-up after. And so that's a really hard one. If you're uninformed, then you can't know what you're doing wrong and what you need following.
Yeah.
Yeah. So whether the radiology staff responded appropriately to the medical emergency?
No.
The expert witnesses were unanimous in their criticism of the radiologist for failing to identify the seriousness of Mrs. Willisdorf's condition.
Yeah.
Also for failing to respond adequately to her blood pressure by only giving her 50 mils of fluid. And the failure to provide adequate monitoring following the procedure to have identified the low blood pressure before she fainted.
Low. Yeah.
Before she fainted. Or, a trend of that. I'm impressed that she managed to walk to the bathroom, to be honest. But apparently there's a little delay in terms of how long it takes your blood pressure to drop.
Yeah.
And then they were also critical of the fact that he didn't provide supervision during her medical emergency.
Yeah. Just left it to the practice manager. Like, you just deal with this. I'm going to go do something
I'm going to do
else.
something a little bit easier.
Yeah, and I remember the first time I read this way back when, not really capturing that he was stating that he was going to help, such as getting the other emergency personnel in and all that kind of stuff. But I just thought he just went back to work and was just like, we got this.
It did sound like he was clearing patients from various
space.
Rooms. Like, I don't know whether that involved doing his
other work.
or not. Yeah. But the ambulance only arrived 8 minutes later, so there's not enough time to
what did
do
you achieve
anything
at that
else.
point?
But it is enough time to do CPR.
Yes. Expert witnesses were critical and stated that Mrs. Willisdorf should have, from the point of the critically low blood pressure reading, been continually monitored, including heart rate, oxygenation, and frequent blood pressure checks, which were not done. Or there's no evidence to suggest that they were. And that she should have been given a significant fluid bolus of at least 500 mils, up to 1,000, to increase her circulating blood volume in an attempt to improve her blood pressure.
Yeah.
During the inquest, it was established the radiology clinic was inadequately equipped for a medical emergency, but did in fact have a pulse oximeter and an ECG machine, neither of which were used for Mrs. Willisdorf.
Were they? I wonder if they were ever used at all.
Good question. They didn't even talk about where they were located. So
were they even aware that they had
cupboard?
them?
Yeah, bought them when they set up
the radiologist
practice.
was.
Yeah,
but maybe the others who aren't medically trained who wouldn't know what
they wouldn't know how to use it.
Yeah, they're not trained to use. I mean, I feel like most people these days know what a pulse oximeter is and how to use it. You put your finger in it. Yeah,
but would they know the meaning behind the numbers that are on the screen? Probably not.
Yeah, they may not. And they shouldn't be expected to. And they may not know where it is. They may not know how to turn it on, use the equipment, how to do it correctly. So even if they tried, they may have also been using it incorrectly that then also could have confounded errors there. And then the clinic didn't have a defibrillator or appropriate other medicines or fluids to be utilised during an emergency that could be reasonably expected to occur in a radiology practice where they're giving people contrast or doing procedures that could result in low blood pressure. And then the expert witnesses felt that aggressive treatment for the low blood pressure would have more than likely prevented a cardiac arrest.
Wow.
Going back to that situation around the pathologist being like, this wasn't a contributory event, I'm like, but she probably wouldn't have arrested.
Yeah, if she hadn't had that low blood pressure, which she wouldn't have had the low blood pressure if...
She wouldn't have had the low blood pressure if she hadn't had the epidural, but she also may not have arrested had they actually managed the blood pressure. And then once she had arrested, would she have done better or had she been given some CPR?
Definitely. Well, she would have had more of a chance.
Yeah, it's hard to determine from there, but there's so many steps there that I'm like, yes.
Could have intervened there, could have intervened there and there and there.
And so I think it is a contributory event to her death. And that, for me, I don't know, that was one bit that I really struggled when I first read it, was like, what do you mean the epidural didn't have an effect leading to her death? The radiologist did concede that it was a poor decision for him to not be present with Mrs. Willisdorf, given her clinical deterioration. And when further questioned about considering commencing resuscitation, the radiologist stated he, and I quote, totally blanked out, but accepts that he should have recognised it as a medical emergency and commenced resuscitation efforts. Experts furthered their opinion by strongly advising commencing immediate resuscitation attempts if a patient loses cardiac output or stops breathing, and that this should continue until further assistance arrives, such as paramedics. So just for everyone out there, if you're in this situation, you should start CPR if you have an unresponsive human being.
And if they'd had first aid training, they would have known that and known how to deal with that situation.
So we're going to come to that.
But that's right.
With regards to the lack of initiation of first aid measures, the practice manager provided conflicting evidence to what was provided by others. And this is where I come back to that, like, I think they were married. I think that there was some potentially unintended biases here around the information that the practice manager provided in attempt to protect the radiologist. Because she stated that Mrs. Willisdorf hadn't fainted following her procedure.
She just wanted to lie down?
No, she just said no, she didn't faint. She said she was feeling woozy, but there was no fainting. And this is despite multiple other witnesses being like,
no, she definitely fainted.
She has fainted.
Yeah.
And additionally, she also stated that Mrs. Willisdorf was, and I quote, talking like a radio while lying on the bed and had to be encouraged not to speak.
Talking like a what?
Talking like a radio, like as in non-stop.
She just kept on talking.
Yeah.
Talking at you and not a conversation with you.
I don't know about anyone else, but I don't think that people with no pulse talk.
She furthered this by stating that Mrs. Willisdorf was full of energy and suggested that by the time QAS were called, they had convinced her not to talk anymore.
Because she was dead.
They had convinced her not to talk.
By not giving her CPR.
When they called the emergency services, we don't think she was necessarily arrested at that point.
No, she would have been semi-conscious, you would think, yes. But
yes. The practice manager did concede that by the time of the ambulance arrival, Mrs. Willisdorf was not talking anymore.
Mm-hmm.
That time you can be like, because she was arrested. The practice manager also refuted that Mrs. Willisdorf was cold to touch or blue in colour when the ambulance officers arrived, and also denied advising the paramedics that she'd been gasping for air prior to their arrival. As we've mentioned, she doesn't have any clinical or medical training, but during the inquest, she did claim that she'd completed a resuscitation training course prior to Mrs. Willisdorf's medical emergency.
Mm-hmm.
However, she was unable to provide any specific details about this course, including the details of the registered training provider or date of completion or exact location to where she completed it. So feel free to make your assumptions however you want there.
Yeah, either she didn't do it at all, or she had done one, but it was like 20 years ago and she can no longer remember any of the details.
Or it was like not a registered training provider, so it was like a casual, like at the back of someone's house, we're teaching you CPR. That then, if you're not a registered training provider, you are not providing the sort of services that this person needed to be working in that position.
Yeah.
Because to be honest, I think that if you're working in any kind of medical facility, there needs to be, and it may not necessarily need to have been the practice manager, but there needs to be at least more than one person that has those kinds of skills.
Yeah.
And realistically, I don't think that it's unreasonable for everyone who works in that practice to have a basic...
Yeah, to do basic first aid.
Yeah, basic first aid certificate.
Doesn't take very long. It's not that hard.
Yeah. But again, I've been in that industry. I've been in that area that maybe I have a slightly biased view on that. So maybe it's, you know, even if it's just pulled back to at least a person per shift or something like that, has some understanding.
Yeah.
Because again, in a radiology practice, if you're just doing x-rays all day, the chances of someone just arresting is probably going to be very low.
Yeah, it would be the same chances if you saw someone on the street.
Yeah. Anyway, so the coroner found the practice manager's evidence largely misleading, with the exception of the description of Miss Willisdorf's breathing that she then refuted anyway. But the coroner was like, no, that probably was correct. She probably was gasping like that.
Yeah, and she probably would have been.
Yeah.
Shortly before.
They went through, again, a long speech around that's actually called agonal breathing. That's the kind of breathing you have just before you're about to die.
Yep.
Right.
And so she probably was describing agonal breathing quite well.
Yeah.
So the radiology clinic guidelines specified that the radiologist was the sole individual qualified to use resuscitation equipment and lead in a medical emergency. Hence, the coroner was not critical of the practice manager for not initiating resuscitation efforts, because actually their clinical policies suggested that it should be, in fact, the role of the radiologist.
Yeah, it was someone who should have been in the room who had a higher level of understanding and training.
And should have been doing it, yeah.
Who should have been the one telling everyone else what to do.
Yeah. And so hence the coroner recommended changes in the practice's policies to improve skills for future medical emergencies and ensure compliance with the Royal Australian New Zealand College of Radiologists standards, which included that the radiologist should have a first aid course which includes advanced resuscitation skills, so not just a basic life support certificate. And the difference in that is that you end up with airway management and drug administration that should be known to that lead medical officer. Also that you should have those drugs and medicines available in the clinic if you have that skill.
Yep.
And that is also in line with the Royal Australian New Zealand College of Radiologists standards. And it was found out that the radiologist had completed a previous resuscitation course, but it wasn't in the advanced level as recommended. They also recommended that the radiologist participate in a CPD or continual professional development program annually to, again, upkeep and maintain these skills, and that they have annual refreshers of advanced resuscitation skills as well to make sure that they are staying up to date with the practices and the skills, because they're not something you're going to be using every day.
No.
So if you then do the certificate once every 5 years and happen to have an emergency in 15 years, your memory may not be
You couldn't
as
expect it to be.
Yeah. They also recommended that the practice updates its policies to require a medically qualified person with advanced skills other than the radiologist involved to be available and assist with patients in a recovery setting. And this was because, as I mentioned, he was both the primary medical officer working at the site, but also the owner of the business, having to coordinate other conflicting responsibilities that are like, well, there should be someone else that's not you solely responsible for the medical care. So such as adding in a nurse with advanced skills or having another radiologist that's employed by the practice to alleviate that, because they were also like, you know, he went off to deal with other stuff in the business, such as letting the emergency staff come in. And was that because he was thinking more from a business side rather than the medical side about how to facilitate this medical emergency? And so they're like, we'll take the load off of you by having someone else there to support you from that perspective. They also suggested they should get appropriate equipment, so that just the pulse oximeter and the ECG machine was not enough. This should include things like a defibrillator and other appropriate equipment for a medical emergency, and that they should record and document medical emergencies should they happen in the future as well, which, as we mentioned, there was just no documentation about her attendance really at all, other than she had a booking. So the emergency services call, I am really interested that they actually even reviewed this, because I'm like, they got an ambulance there in 8 minutes. What were they reviewing from this perspective? But it was more about how the phone call developed, and then the fact that the paramedic showed up without being aware that she really needed CPR. So the call was received at 1:27 and answered by actually a medical officer working in the centre. So it wasn't their standard call centre staff who may not necessarily be medically trained. It was a medically trained personnel. And so they didn't adhere strictly to a specific script or protocol because of that individual's background. The radiographer was the person who made the call, and they detailed that she'd undergone a procedure and had become unresponsive at the radiology clinic. And then in the background, the radiologist can be overheard stating the ambulance needed to, and I quote, be here now. And the case was assigned by the call taker as a priority code 1B, which was lights and sirens, due to the risk of a potentially life-threatening condition. And this was identified 97 seconds into the phone call. And then, as I said, they arrived 8 minutes later. So I think that that's all pretty good. Like, I think 97 seconds in, by the time you have to have, like, identified yourself and where you are and all that kind of stuff.
What's happening.
A phone number for them to call you back if they need to.
Yeah. So for me, I'm like, 97 seconds sounds really good. But I guess it was that not identifying that CPR needed to have happened.
And are there specific, like, time frames that they look for an ambulance to arrive for, like a category 1B?
Yeah.
I would assume 8 minutes sounds pretty good, though.
Yeah, like, unless the ambulance was, like, next door.
Yeah.
I don't know that many could get there much quicker than that, to be honest. But yeah, the paramedic in the inquest who attended argued that had he known that they were attending a cardiac arrest, then they would have taken the equipment in earlier and that kind of thing. So an expert witness from the Queensland Ambulance Service delivered evidence to the inquest and felt that no difference would have occurred in the response time should they have known.
And there were already lights and sirens.
Yeah.
What's a category 1A then?
Is a cardiac arrest in progress.
Yep.
versus a potential life-threatening event.
But even if it was a category 1A,
I don't know that it changes the time
Exactly,
frame,
I
but
don't
it
think
might
it would've
change what
done
they take
anything.
with them
Yeah.
out of the ambulance.
In the first instance.
Basically, the expert witness was also like, it was a difficult phone call. The radiographer didn't really know the answers to the questions being asked by the medical personnel.
Like, are they breathing?
Yeah, when they were asked the question, are they breathing? She said, I'm not sure. And then it never circled back to like, are we sure about the breathing situation? And that's where I think a script would have helped.
Yeah, because then they do the whole, tell me when they breathe.
Yeah.
And they count it out. Yeah.
Well, you say that, but they went on to say that the standard operating procedures of the medical priority dispatch system was reviewed in 2015. So this happened in April of 2015. Yeah. So at some point in that year, to incorporate questions about resuscitation. Okay, so I actually don't know if prior to that
it was in the script.
Yeah, but I think that's only as of 2015.
Yeah, right.
The expert witness confirmed there is now a sequence of questions about whether assistance or instructions about resuscitation is required, so such as prompting them to start resuscitation as well. And so the coroner was satisfied that those changes were already previously implemented, and so no further recommendations from this inquest needed to occur, but were not in use at the time of her death. So ultimately, overall, the coroner concluded that an epidural injection was the most likely procedure that actually occurred, but was not the most appropriate. But it wasn't pertinent to assess the adequacy of the radiologist's skill in performing the epidural procedure, because he in fact did this successfully, by the fact that she then went on to have low blood pressure. And so it was rather the adequacy of the response was the crucial part of this inquest, and hence found that there was substandard care, all combined to jeopardise Miss Willettsdorf's survivability of her medical emergency following the procedure, which then ultimately contributed to her death, which, as I said, he then said, yes, this was contributory. So further recommendations that I haven't discussed that the coroner recommended to the radiologist at the time of the findings included purchasing a defibrillator, purchasing fluid bags, creating a designated recovery space with better lighting, because there was those arguments about whether she was in fact blue when the ambulance arrived, that they implement continuous monitoring of patients who've had significant procedures, such as the one that was performed on her, that CPR training is carried out and there's a record of who has that training with certificates and actual providers. And then the radiologist does not perform any more T12 epidural injections. It was actually documented that he had not performed any since this event at the time of the inquest. The inquest was completed in 2018, but the findings weren't released until 2020. So there was a long delay between the inquest and the release of the findings. And so ultimately these findings were 5 years later. Yeah. So in that 5 years subsequent, he hadn't performed any more of these procedures. The radiologist had actually wanted to make change, and so he had done a lot of this stuff off his own back already anyway, including having a member of the Australian Diagnostic Imaging Association undertake an independent review and assessment of the current policies and procedures at the practice. And the coroner was satisfied with the content and the recommendations made, and then recommended that the radiology practice make sure these are all implemented within the 6 months of these findings being released, and that they have another review again 12 months later for any further recommendations and implementations of changes.
Yeah, okay.
Based on that. So ongoing continual improvement of the practice and its policies and procedures. Additionally, the coroner recommended that the radiology practice is more selective with its patient cohort and only performs imaging and interventional procedures following assessments of patients and determining their safety to undergo the planned procedure. And then the coroner ultimately made a recommendation to the Royal Australian and New Zealand College of Radiologists as well, which I think goes a little bit beyond the standard recommendation of he was just recommending a lot of this to the actual radiologists involved. But he said, no, actually, your standards for the college should also be higher, such as making sure that monitoring is available for patients undergoing these procedures in these radiology clinics, and that they need to report back to the coroner's court after the completion and of the amendment of their standards of practice. And that the radiologist curriculum requires radiologists performing any kind of procedure, including contrast and sedation, to hold a CPR certification to provide advanced skills in life support and to report back to the coroner that they have updated their curriculum as well, which I thought was kind of pretty strongly worded to the college, being you need to change this, and you also, I recommend you change this, but also you need to tell me when you changed it.
Done it, so that I know that you've actually done it.
Yeah, so it wasn't really a recommendation. It was, this must happen.
Yeah.
Because realistically, my understanding of the coroner is like none of it's actually
binding.
Yeah.
Not enforceable.
Mhm.
Yeah. So, I mean, what's the college going to do if they don't do this? Like, nothing really changes. That it's not like the coroner can do anything.
The issue is that if something similar happens again,
the coroner will be like, do you remember last time?
Yeah. And but then I wonder when that starts to verge on that criminal negligence kind of.
Yeah.
Yeah. They're like, they've been
told once.
Yeah.
Exactly. Whether they potentially can consider criminal charges.
Yeah.
I don't know, but
yeah,
just a thought.
And last time I read this, I thought that the coroner did refer him to the medical board and all that kind of stuff, but couldn't find that reading it through it this time. So maybe I looked it up last time. I'm not really sure, but I couldn't find anything in this. But then he did get referred. I couldn't find the outcome of his review in terms of the medical board review. I only found one case about him asking QCAT to drop the case and QCAT being like, legally we can't, except for they just said no. And then he asked for them to specify why they wouldn't get involved. And that was when the judge turned around and was like, because I legally can't, thanks for making me spell this out and wasting my time.
Yeah.
And now it's a publicly held record. So I really enjoyed that. The judge was a bit sassy. It was great.
Yeah, but in legal terms.
Yeah. And so I don't know, there was no obvious restriction on his license. And so I think reading it the second time, I can see that he was trying to make changes. He was trying to improve his practice. So again, one mistake shouldn't lead to a complete loss of license. It should lead to, well, let's review what we can do to help you be better. And I think it's really hard when you get isolated in he's running his own practice. He's the only radiologist there. There's no one else around triggering that.
To help his development in any way.
Or even just having discussions about maybe we should do it this different way or...
or like if you thought about that complication, you know, you've never had it before, but like what happens if maybe you therefore need to have the recovery room, the appropriate equipment, the appropriate staff, all that kind of stuff. So, yeah, I really enjoyed having a different view of it the second time around and being far less critical the second time around because I'm like, oh no, now that I reread this, I can see attempts to improve. And I think I was critical the first time because of all that conflicting information that was provided. But again, 3 years later and your memory shifts what you think actually happened.
Yeah, it was an interesting one.
I actually don't remember you telling me about that one.
Oh, I totally remember telling lots of people.
Detail.
And so the other caveat here is it's going to sound like I really hate radiologists and radiographers and radiology clinics because it's the second one I've done in a clinic. And it's just a pure coincidence / me coming back across this case and being like, oh, I should do it because that triggered this whole podcast. So apologies
I like that we've done the origin story.
Yeah.
A little bit, yeah. So
that's great.
All right. Well, we will look forward to you tuning in again next time.
Thanks for listening.
Thank you.
Bye.
Bye.